I'm going to be talking today about the management of diabetes in the elderly. Um, these are my disclosures. I am a contracted speaker for this lecture, and I have to acknowledge the slide support that I have received from Dr. Rahul Bhattacharya, who's one of my colleagues. So the world is growing older at an unprecedented rate, and this is probably one of the very valid discussions that we have today, because one of the reasons that coronavirus has struck this world so massively is because of the huge number of elderly people that we have in our population. And today it stands at 8.5%, and it's expected to grow to 17% by 2050. And the number of people who are older will be expected to triple. The main health concern as in other groups is non-communicable diseases. And the main non-communicable disease that we know of today is diabetes, which is underdiagnosed in elderly people, with at least 25% of people older than 65 having diabetes, but about 14.5% are left undiagnosed, and addition of fasting plasma glucose increases the detection threefold to 42%, and OGTT may be needed to diagnose the remaining cases of diabetes. This has been shown in these studies which have been published recently, showing an increased prevalence of diabetes amongst the elderly, not only in southern India, eastern India, and western India, but showing a trend of increased growth of diabetes even in central and northern India as well. So this is multiple publications that have been done. I'm not going into details of it. Suffice to say that the elderly diabetics in India are growing, and we need to be careful about how we want to teach them, because aging is associated with changes in the hormonal profile, and we will focus mainly on glucose homeostasis, which is characterized by reduced amplitude and mass of high frequency insulin pulses. There is a reduced frequency of ultradian insulin pulses and increased insulin clearance. So in effect, you're having less insulin secreted and more insulin cleared from your body, with defects in the liver and the pancreas, which are completely related to the aging process. This is accompanied by a decline in beta cell function. This beautiful paper in Diabetes Care shows you that both first phase and second phase insulin release is reduced as we age. So this is IGT, and this is normal glucose tolerance. And as you can see, this is first phase insulin resistance, 25 years of age and 65 years of age. Look at the decrease in the insulin release. And again, the second phase insulin release, again, you see what a massive decrease there is over the 40 years of age that is involved. Not only that, we also know that old age may be associated with more diabetes-related complications. So these are all elderly people, more than 65 years of age. This side is the cardiovascular complications. These are the microvascular complications. And as you can see, the blue lines, the blue bars, which contain the diabetics, is higher, whether you look at heart failure, heart disease, heart attack, or any stroke. The number of people with elderly who would get this into diabetes is more than people without diabetes. This is somewhat expected because we do tend to see a lot of our hospitalized patients being diabetic when they're admitted with the MI or a stroke. But indeed, even if you look at microvascular complications, presence of diabetes increases the risk of kidney disease as well as retinopathy. And this is quite significant, as you can make out, the blue bars being far larger than the yellow bars. Indeed, in the TCOS, the overall outcomes in all groups of patients was far worse, whether you looked at primary CV composites or hospitalization for heart failure, mortality, or any kind of problems. It was seen that it was worse amongst people who had diabetes. Take into account two very important factors. Severe hypoglycemia was worse in people who were elderly, as well as bone fractures in people who were elderly. This is from the TCOS trial. So of course, that brings us to the very important issue of hypoglycemia in elderly, because symptoms may be non-specific, and there's often a misdiagnosis of stroke, vertigo, visual disturbance, may be misinterpreted as psychiatric problems, and patients may present with confusion or passive delirium, and there are other problems with little warning or unawareness of autonomic symptoms, making this awareness of hypoglycemia being absent a major problem in patients who are elderly. Add to this polypharmacy because of multiple diseases and multiple problems and multiple symptoms. Elderly patients are on polypharmacy, and the elderly people tend to take much more medicines than younger patients, and 12% take more than 10 medications weekly. Elderly people seem to be having more adverse reactions, and drug interactions are also 80% more common in patients who are elderly. So are everybody that we see above a particular age elderly? No, it's not the same old story. There are three categories of elderly. There's the functionally independent type. This might be a 75-year-old man who lives alone, plays golf, has a wonderful life, goes out with his friends, and leads a completely normal life without anybody helping him out. He is functionally independent, so he's category 1. The second category is functionally dependent, who due to loss of function have impairments like problems with bathing, dressing, or personal care. They need help, and they might be of two categories: who are frail with significant fatigue, weight loss, and restriction in mobility, and B, those with the mental health issues with a degree of cognitive impairment, memory problems, and disorientation. The category 3 are the elderly who are just about to die, unfortunately, and have a life expectancy reduced to less than 1 year. So the ADA has fixed targets for these elderly. For the first group who are healthy, who are otherwise fine, the HbA1c target is 7.5 or less. The people who are having complex diseases, the group B, which I alluded to a little while back, intermediate remaining life expectancy with high treatment burden and a tendency for hypoglycemia or fall. You can go for a target of about 8%, and people who are severely ill, you can go for about 8.5%. There are also suggestions that if your person has a less than 1 year expectancy of life, you do not even need to measure blood sugars or HbA1c. Make sure just that the patient does not get any symptoms of hypoglycemia. Blood pressure also should be controlled, as well as lipids, and these are things that we have found in the ADA algorithm. So how do we treat them? The basic philosophy is to make sure that we look after them in a completely holistic way, looking after their medical, psychological, functional, and social problems. We should be making sure that there are no geriatric syndromes which they might be suffering from, which would be affecting their diabetes, and address those issues as well. There are certain issues that we need to consider in a little bit more of detail. The first thing would be the neurocognitive function. We need to make sure that their cognitive impairment and dementia and depression is dealt with adequately at every visit and annually. We need to make sure that hypoglycemia is avoided at all costs. It should be assessed and managed by adjusting glycemic targets and pharmacological interventions. Indeed, relaxation of glycemic targets is strongly recommended. And also, we should make sure that acute hypoglycemia symptoms and complications should be avoided, and treatment should be directed to ensure that cardiovascular risk factors are addressed and cardiovascular disease and outcomes are dealt with adequately. For this, there are many drugs: metformin, sulfonylurea, TZDs, SGLT2s, and gliptins are the common orally used drugs. Metformin tends to be a source of GI irritation, and sulfonylureas tend to cause hypoglycemia. TZDs have a problem with edema and fractures, osteoporosis being a big problem in the elderly, as I showed you earlier. SGLT2s come with their inherent risk of genitourinary infections and volume disorders. Gliptins, on the other hand, have no specific age-related tolerability issue. So what are the impact of therapies on age? So gradual reduction of EGFR and gradual reduction of active beta cell mass is almost a sine qua non of aging, and with reduction of EGFR, efficacy of SGLT2 may be reduced, and with the reduction of active beta cell mass, efficacy of sulfonylureas may be dependent on active beta cell mass, and that may be reduced. I would also like to show you this recent publication that we have had in Nature, which we have demonstrated that pioglitazone probably has no benefit in type 2 diabetes. All the benefits by way of cardiovascular disease benefit are probably restricted to people who have insulin resistance and prediabetes. And if you look at them specifically for type 2 diabetes, the risk of heart failure, fractures, and anemia far outweigh the benefits that are kind of promulgated for pioglitazone. And this, I'm very happy to show you this because this has just been accepted for publication in the Nature journal. Sitagliptin also is effective in patients with poor beta cell function. Even patients with worsening beta cell function have good efficacy of sitagliptin because of probable effects on beta cell regeneration. And indeed, in Indians, which my colleague and friend Suresh Damodar and Russ showed you a little while back, there is probably more efficacy of sitagliptin or any DPP-4 inhibitor, even with worsening of beta cell function. Not only that, gliptins continue to be effective across age groups. In this beautiful study, in the ASSIST case study, which looked at people in 3 age groups, 64, 65 to 74, and 75, there was a similar HbA1c reduction across the board with no loss of function of sitagliptin due to age. And this is a massive pat on the back for sitagliptin, which shows that even with increasing age, you can continue to use this drug. This is age independent. As you can see, this is elderly patients, less than 75, more than 75, and all patients, similar HbA1c reduction, which is, however, not seen in canagliflozin, where with increasing age, there is a reduction of the power of reducing blood glucose. And this has been seen across the board. That one was with canagliflozin. This is with empagliflozin. With advancing age, most people go through a reduction of EGFR, and a reduction of EGFR translates into a reduction of efficacy in reducing HbA1c in SGLT2 inhibitors. In fact, it is a package insert of all SGLT2 inhibitors that use with caution above the age of 80 because of this problem and also the fear of hypotension and hypovolemia. There is again this function of renal function, wherein you see with worsening renal function, empagliflozin starts to lose its value. This is the pooled analysis of phase 3 trials. And this is from a publication in 2015, where the worsening of EGFR is associated with reduction in the power of reducing hyperglycemia. So sitagliptin, on the other hand, whether you use it in a dose of 150 or 25, according to EGFR, continues to maintain a similar amount of HbA1c reduction of about 1%, irrespective of the EGFR, and has no deleterious effect on EGFR, continuing to maintain renal function throughout all stages of kidney disease. In fact, if you compare sitagliptin with dapagliflozin in mild renal failure, sitagliptin was superior to dapagliflozin by reducing HbA1c more by about 0.2% in patients who had stage 4 kidney disease. Again, with insulin, if you compare insulin and sitagliptin, there is a very good documented reduction in the number of hypoglycemic events to the tune of about 27%, which was statistically significant, with more HbA1c reduction in the arm which used sitagliptin, which is a sign of how powerful the molecule is, yet maintaining good glycemic control without hypoglycemia. And though there was no worsening of outcomes in the elderly with sitagliptin due to usage of sitagliptin in the TCOS style, I have already shown you that if you take the whole group as a whole, you find that there is some risk of worsening of outcomes in the whole group. An important area is osteoporosis. Elderly people have defects with multiple hormonal problems. There are architectural abnormalities. There's reduced resistance to mechanical stress. There's more fractures, and of course, conditions like hypoglycemia, neuropathy, hypotension, eyesight worsening, foot ulcers, vitamin D deficiency increase the risk of falling and worsen the risk of fractures. And certain drugs like thiazolidinediones and query SGLT2 inhibitors have been implicated in this increased risk of fractures or increased risk of osteoporosis. This is a very real issue because of person with a fractured neck or femur has a 5-year mortality, which is even more than cancer or heart failure. So these are the effects of the drugs on fracture risk. And as you can see, the main fracture risk is worsened by 2 drugs, which is thiazolidinedione and a queries there on SGLT2 inhibitors. So this is again odds ratio of which drugs tend to do it more. So 45% risk with thiazolidinediones, huge risk actually. We've shown in the paper that I alluded to a little while back that we demonstrated that if you treat 80 women above the age of 65 with thiazolidine, you have a risk, you need about, if you treat 80 people over 3 years, you will have one extra fracture. So it's pretty high risk. SGLT2 inhibitors, it's debatable, but I would say that if somebody is at risk of developing fractures or at risk of falls, probably best to avoid SGLT2 inhibitors. The DPP4s and GLP-1 analogs are completely safe as far as fracture risk is concerned. Of course, the other reason that we're concerned about using is sarcopenia, the muscle loss that we see in patients with diabetes and the elderly. And again, this study very clearly shows you that there is a statistically highly significant improvement in all parameters of skeletal mass index, and hand grip strength in patients who are elderly who are on DPP4 when compared to the sulfonylurea group. And indeed, you find that usage of DPP4 inhibitor is associated with an improvement in skeletal mass when compared to patients without DPP4 inhibitors, which would suggest that this has a major effect in reducing the risk of sarcopenia in the elderly. There is also ongoing research and developing evidence that there is an improvement in mini-mental state, which is important in cognitive function in elderly patients in diabetes with or without Alzheimer's disease. And therefore, we come to the final consideration that proper drug selection that can address the pathophysiology has to be taken into consideration. May be difficult to just follow LSM, simplify regimens, avoid polypharmacy and drug interactions, treat according to comorbidities, assess ability to self-medicate or access to support in the family, and make sure you set certain guidelines which balance between efficacy, sustainability, tolerability, and make your goals clear to the patient and family. And in this situation, gliptins provide a wonderful addition to the armamentarium for the treatment of people with diabetes who are elderly and can be a go-to drug in this situation. Thank you very much.